Thank you. Okay, I'm going to get started, guys. Great. So welcome everyone to the ANZUS Trauma Grand Round for August. For August, this is our first for 2024. So welcome everybody. My name's Kate Martin. I'm the president of the Australian New Zealand Association for the Surgery of Trauma, and I'd like to start by acknowledging the Aboriginal and Torres Strait Islander people as the traditional owners of the land which we are all on today, and extend my respect to elders past, present, and emerging. RACS respects the Ngāiwa Māori as the tangata whenua of Aotearoa and is committed to upholding the principles of Te Tiriti o Waitangi, fostering the college's relationship with Māori, supporting Māori fellows and trainees, and striving to improve the health of Māori. So it gives me great pleasure to introduce you all to our new chair of the Education Committee of ANZUS, Dr. Martin Jarman. Martin has put together a really great panel of speakers today, and we're returning to a topic that we actually started with when we first started these Trauma Grand Rounds back in 2020. However, it is an update. We thought it was important to have this topic again because it is such a important part of the surgery that we do, particularly in the major trauma services. So I'm going to hand over to Martin now to introduce our panel and just to give you a bit of an outline for the evening ahead. Thanks, Martin.
Good evening, everyone. Good day from Perth, Western Australia. It's my honor to chair this Trauma Grand Round, and just a few housekeeping hints. If you can, you will all be muted while the presentation is ongoing. If you have questions at the end of the session, please write it on the chat and we will address them one by one to the panelists and to our speaker. It's my honor to introduce as well our speaker today. I had the great privilege of being his fellow almost 10 years ago now in Newcastle and John Hunter. He's a professor of surgery and traumatology in John Hunter Hospital and the University of Newcastle. I give the floor now to Professor Zsolt Balog.
Thank you very much, Martin and Kate and the ANZUS Executive and Education Committee to present here. I would like to acknowledge the Awakabal people here where I'm talking from, and a continuous connection to this amazing land, air, and water for tens of thousands of years. And the today topic, as Kate mentioned, is related to a pelvic injury and traumatic shock. And I would like to highlight the fact that this is pelvic ring injury, not necessarily pelvic fracture, because frequently these injuries not associated with a fracture. So as Kate also mentioned, almost exactly 4 years ago, we had this comprehensive topic about severe pelvic injury management from the beginning to the definitive management. And today we are doing an update on this. And I'm connected to these topics quite a while from now, and I would like to acknowledge all the countries, continents, mentors, and trainees and colleagues who have worked on this and helped me to be confused on this topic on a much higher level than I used to be. So today's aims are the focused overview of the shock pelvic ring injury. I'm presenting obviously in a grand run style with lots of personal bias and building on the 2020 October grand round. And I try to interpret for you guys my own work, which I have firsthand experience, and share with you some recent evidence. The problem that today I cannot be really controversial because compared to my previous talks on this topic and during the last 25 years, the evidence is getting crystallized and getting much clearer what's going on today. So let's go ahead and talk through this. So the German Trauma Society describes these components of severe complex pelvic fracture, and we are going to talk about the top. But as you can imagine, these things underneath open fracture, nerve injury, urogenital and anorectal injury almost always at least partially associated with the problem with hemodynamic compromise. Most people start this talk about classification. The only reason I put up classification slides, Young and Burgess and Tile, just not to bother about it. It's absolutely not needed. Any of these pelvic ring injuries can bleed. Most people cannot anyway classify them and call all of them just open book. And there is no relevance, not much of a relevance to the management. And humans just try to classify things what they cannot understand. And once they understand, they don't need for classification. So, but this is roughly the problem that you see. On this pelvic ring is nothing right. And you can imagine that it can be classified by any means. And you have a hard time to tell what was the mechanism. But only thing what you know that you spot that this is a huge problem. And if I go back, what was going on 20 years ago in Australia, we've done a big multi-institutional survey, how these patients do just in the major trauma centers. And at that time, the mortality in Australia was 32%. And just, I would like to ask you to remember to this 32%. And as you see that anything bad on this slide, you see that unnecessary interventions and the interventions which were needed haven't been performed. And in response to that, we developed some guidelines in the Liverpool days in 2003. And with this, we managed to decrease mortality from the usual 35% to 7%. And that was in 2003, more than 20 years ago. So in this slide, I can summarize what is the optimal practice in 2024. You need to have expeditious, preferably direct transport to the trauma center in a binder. You need to perform hemostatic resuscitation, starting with plasma and platelets. And if the transport time is longer than 15 minutes, it's best to start it pre-hospital. In hospital, you need to have available, if it's needed, a rapid selective angioembolization, and you need to be prepared for acute or at least early definitive, preferably less invasive internal fixation. And these last two, the angioembolization, imaging, and definitive fixation, preferably need to be in one place, under one roof, in one room. Well, most people start out when they talk about a difficult topic that, oh, this is a very short time to cover this, or I can't cover this in a small article. But I think if you understand this, you never start a lecture out there. And anyway, if you want to, if you don't understand my accent and then just want to read something short, I recommend this paper, which in 1,000 words is a concise summary of everything what you need to do in this topic in 2024, or how to save your patients. So why is this topic significant, as our president said? Because these patients tend to die in more than 1/3 of the time if you don't have a systematic approach. The injury is not particularly frequent, but frequent enough to mess up your preventable mortality, because it happens about 10 to 12 times if you look after a 1 million region in a major trauma center. And the death in 2024 is due to arterial bleeding. And it will pop out on your MMM, and it's just going to make things really, really bad. And the definition of this problem, for me, if you have a mechanically unstable ring and the patient needs transfusion in ED, that's kind of pinpoint these patients. And why I'm saying this is a arterial bleeding problem, if you see this paper, when this table summarizes the pelvic fracture-related arterial bleeding versus non-pelvic fracture-related arterial bleeding, these two groups are completely different patients. But the most striking difference between the two groups, that the pelvic fracture-related arterial bleeders tend to die, and those ones who have no pelvic fracture-related arterial bleeding, they tend not to die. So with this, the venous bleeding and all sorts of things, I think I can put into the coffin. So venous bleeding, if you have pelvic binders and you properly resuscitate these patients, is not a problem. Pelvic binder is essential for good temporal reduction and a low complication rate. You can keep them overnight if you do the definitive fixation in the morning, and eliminates the need of crazy devices acutely, which just distract main things from the focus. I don't use usually internet source images, but I put this up all from the internet and all about the pelvic binders, and they're all wrong. And if you go around the world and looking lectures around this topic, you see these all. And all of them are wrong, and all of them are wrong from one reason, but all of the legs are widespread and abducted, and you can put even a shopping bag in between, and that means that the pelvic ring cannot be closed. Pelvic ring is most efficiently closed via the femora as levers, and even during operation, I frequently use for reduction a low position binder, or even just around the knees. It is much more efficient than having a belt around the pelvis and the legs are wide apart. So all what I'm talking about in the context of limiting initial damage and optimizing resuscitation with hemostatic resuscitation, which I won't go into the fine details because we can have separate ground runs on those. So this means that if you provide early on, within the first half an hour, blood and factor-related resuscitation, the venous bleeding is not an issue. It eliminates the need for pelvic packing. And again, I emphasize that these patients need clotting factors rather than just blood. And during the last 15, 20 years, we managed to make a huge progress on that earlier start of resuscitation, eliminated the need frequently for massive transfusion protocol, and whatever fluid or whatever components you look at, everything just we need less and less, just because we're starting that early. And that's universally available around the world. This is a title slide and main chart from the Oslo group, who 10, 50 years ago were crazy advocates of pelvic packing. And what they realized that with better resuscitation, the need for pelvic packing is absolutely disappeared. They do still a few angioembolization, but they don't need to do crazy procedures which associated with death. And in our institution, we looked at the timing for pelvic angioembolization, and we see that although our mortality and survival is improving, the time to angioembolization is slightly increasing, because we embolize patients not necessarily in a life-saving measure, but targeted finding on CT scan or when things are already under control. So that makes a huge difference. But angiography remains a good gold standard, because it stops bleeding in a minimally invasive fashion where it's need to be. And the trick is that we need to provide it as fast as we can provide surgery. The reason why it's important, because many of these artery or pelvic bleeding are not actually inside the pelvic ring. So you can actually pack them, but you need to pack a more proximal artery to stop them. And you need to pack over the systolic blood pressure, which means there's nothing gonna survive within the pelvic cavity. So this is an example of a superior gluteal artery, which bleeds to the buttock outside of the pelvis. And this is an example of pelvic floor pudendal artery bleeding, which is again bleeding outside of the pelvic ring. And this is how it's controlled. We see the coil here and the definitive internal stabilization within 3 hours of arrival. And some of the bleeders are much more difficult to assess. This is a patient who had open pelvic fracture, open to the perineum with grossly displaced pubic ramus, and this was inside the external iliac vein. And you see this severe runover pattern and open perineal injury. So this lady was taken up to the operating room in the middle of the night. We positioned flat supine, done internal fixation, and controlled the internal iliac vein injury with a little bit of blood, but not excessive. And this allowed to position the patient in a lithotomy position and sort out the perineum and the injuries there. And this is, you see that the results of internal fixation, and next day the patient can sit up and get on with life. Well, our timing to definitive internal stabilization, especially in the polytrauma and traumatic shock patients, decreased during the last 15 years from the 1 week mark, this is in hours, to roughly the 1.5 days mark. And we recently performed a systematic review which compared the data available for pre-peritoneal packing versus angioembolization. And you can see that 27% of the patients who needed pre-peritoneal packing did not get adequate hemorrhage control and required angioembolization. And in my books, these are the patients who would need angioembolization to start with. And they just need get an unnecessary procedure to delay definitive control. And if you look at this summary slide from this graph with selective angioembolization, the more recent data shows improvement in outcomes, while the pre-peritoneal packing literature is just plateauing out. Well, if you think that this is all biased, then it's just my particular way of thinking, then I would recommend you from a top surgical journal, 2002 November paper from the United States of America, looked at anybody 18 years and over, receiving 4 units or more PEC cells with pelvic ring injury within 4 hours. And they looked at almost 1,400 patients. And they looked at what happened if they had angioembolization, pelvic packing, or REBOA. So this is currently the biggest study in a best journal and looking at really current practice in a world leader country. And what they looked at it, that the only angioembolization decreased mortality. Pelvic packing was ineffective in hemorrhage control, but increased the complications. And in those patients where REBOA was used, it was ineffective, and the patient just died before they could have any complication. And most astonishingly, the mortality in this contemporary cohort in the United States of America on the highest level of care in this hemodynamically unstable pelvic ring injury patient is 36%. And remember my historical slide in Australia 20-25 years ago, when we were absolutely devastated, or local standard of 32% mortality across the level 1 trauma centers, and started some systematic work to improve. And if you have 25 years later in a world leader country in trauma care with that mortality, I just really caution to follow blindly anything coming out of there. It's really concerning with the most expensive care that these are the outcomes. Well, I cannot really complete lecture or ground round about this topic without mentioning open fractures, because they are most frequently associated with hemodynamic instability, and they need a slightly different strategy, but in principle the same. So open fracture means that open through the skin or open through mucous membranes, vagina, bladder, or rectum, or in some cases both. They are relatively rare. It's something like happens in just around 3 in a million. So we tend to see here a few in a year, or sometimes we skip a year and then they pop up again in the next year. And they are more frequent in pre-hospital deaths, but we have anecdotal experience that the pre-hospital deaths in this category, they're getting less and less with a much better retrieval system in our vast geographic area. And it's a funny or sad fact that it's more frequent among children. In children, pelvic ring injuries very rare, because from car crashes or falls, they don't really happen. The pelvic ring is flexible enough to not to break. The most frequent mechanism in children for pelvic ring injury is being run over by car. And with that way, they just splat out and very frequently having open pelvic ring injuries, which are devastating, challenging things to manage. So the management principles in these open injuries are not different. They need hemorrhage and contamination control. So the contamination control is in addition to the closed fractures. And the urgent packing of the wound in ED or pre-hospital and putting the binder on the top of that is crucial, because these patients can openly ooze from these fractures. And in this situation, even with a good hemostatic resuscitation, the venous bleeding can be problematic. And then we reassess physiology, and they need the same way angiography, and they need definitive internal fixation. So this is a patient being hit by a car. So you see that some of these urban situations can be so aggressive that you don't need to go to war to see blast injuries or things like that. This happens, unfortunately, on our roads or suburbs. So the key thing is that in some of these most horrific injuries and hemodynamic instability, you need to make the call for urgent amputation or urgent hemipelvectomy, which seems to be life-saving based on several case series now. So you do this X-articulation or amputation with resuscitation at the same time, but actually you still fix the pelvic ring minimally invasively to keep the remaining stability together and have the ability to manage these catastrophic soft tissue injuries and urogenital injuries with a safe, stable framework. Well, you could say that, okay, these are the old Liverpool data is anecdotal, but we just last year put this out that we had in the last decade, we haven't lost any major pelvic fracture patients from hemorrhage. And hemorrhage-related death, we consider anything which acute exsanguination or physiological exhaustion, as is frequently referred in the United States of America towards the later part of the 24 or multiple organ failure closely associated to the initial blood loss. And that's associated with much fewer transfusion and timely hemorrhage control. So this aggressive strategy with early surgery didn't increase mortality, but in the other way around, it helped us not to lose a single severely bleeding patient. And based on our figures, we have 10 to 12 a year. So in a decade, that's over 100 consecutive patients, which is still a small subset, but really not many people can have higher numbers just based on the epidemiology which I communicated earlier. So in response to that, we've been asked to write this summary, which I refer to that. And I can tell you that the way it's formatted in every sentence in this short communication, that many hundreds of days of work behind that, and really, we are not talking about anything historical. We are not talking about what really shouldn't be done or crazy, unproven historical things, just the optimal way we believe based on latest current evidence and local practice, which is applicable. Well, what should happen from now in terms of for the future? Our essential role is making sure that all results can be universal, and we try to promote it everywhere. We having observers, visitors. We try to teach it and explain it everywhere, and just breaking down the usual boundaries. And one of the first boundary, what I frequently ask, is how should we manage patients in places where you don't have angiography? Well, I would say that in the 21st century, in 2024, a hemodynamically unstable pelvic ring injured patient shouldn't go in a hospital where there is no capacity for this. And yeah, the pre-hospital time can be longer, and they can result some pre-hospital deaths. But I can guarantee that who dies in a way to the trauma center, they would die in a regional center without angiography and surgical capacity for sure. Because in a modern retrieval situation with properly bound pelvis and early hemostatic resuscitation, many of our patients received 4-6 units of PEG cells and corresponding plasma pre-hospital, and bound pelvis and arrived to the trauma center. I can't believe that better care can be provided in a facility where no resources are available. The other fact is that one of our biggest achievement in our region, and some regional hospitals from our trauma system along the coast can confirm that they have at least sometimes or consistently angioembolization capacity in regional level 3 centers. And the way we achieve that most of these hospitals has a vascular service. And vascular surgeons today tend to do most of their work endovascularly. So they do these things all the time. And angioembolization is not a specialty. It's a skill set which can be done by a vascular surgeon, a trauma surgeon, interventional radiology, whoever can have the skills to navigate these catheters and deploy balloons or coils and embolize. So in these hospitals, which I'm referring to, vascular surgeons and radiologists put together a combined roster, and maybe in 2 regional hospitals, and surgeons living halfway between, providing roster for both. And we are receiving patients from there with perfect hemorrhage control within few hours after injury, ready for definitive fixation and shock control when hit the trauma center. And this is bigger achievement than anything else I can refer to. If I'm asked about the same topic to talk about this in India or anywhere in China or anywhere in Southeast Asia, and they said, oh, we don't have this ability. They do. Those countries has amazing resources if they want to. They can use the latest imaging technology. They can use the latest robotic and prosthetic devices in elective surgery. It's just a matter where they put their focus. And they have the top centers, and they have the ability to do that if they want to. So I don't think there is an excuse in the 24th century if a hospital is doing this regularly for elective vascular surgery or even acute AAAs, that they can't do that for the injured. The other potential improvement which we should focus in the future that eliminate this historical movement of the patient among hospital departments. This is nothing to do for the patient. This is just historical role play, and there is no need for it. So it starts for where the patient comes in. All our trauma role play with the badge in the resuscitation bay and performing the primary survey and the 5th time and calling out shots and stuff like that. maybe satisfies egos and somebody who like to do this leadership exercise, but is not really much for the patient. Most of our patients, this sequence, arrived to the hospital by doctor-equipped retrieval service, who had already 3 primary surveys and a couple of secondary surveys. They have pre-hospital binder, pre-hospital fast, pre-hospital transfusion, chest decompression. So the chance that we need to do anything on this intubated and resuscitated patient in the next 15 minutes in a resus bay is practically zero. One of my colleagues looked at 100 consecutive patients coming off from the helicopter to the trauma resus bay. In the next 45 minutes, there had no life-saving intervention done. So all these patients can go straight to the imaging. So the only patient who cannot go straight to the CT scan are the ones who need operation straight away, identified by the trauma surgeon on the helipad, or the ones who most likely just lightly injured and they won't need even a pan scan. Those ones can go to the resus bay and they can have a stay and play with them. So to bring together all these departments, the important thing is to have this CT hybrid suit. A standard hybrid suit is not good enough because you take the patient there without ability to properly image. And I would say that in today's standard, the main reason to take the patient to a CT hybrid suit is they need an operation. And that doesn't need to be anything heroic. But if the patient needs, let's say, a hemorrhage control in the face, they have an open fracture, they have a nasty contaminated wounds or whatever, they go to this room, they got the urgent CT, and they perform the necessary operations on the same spot, and interventions can be done, and any body cavity can be opened. Rest of the patients who don't need urgent operation straight away within the next few hours can go through the CT scanner, which is right adjacent to the resus bay. And this eliminates in polytrauma patients with hemodynamically unstable, with pelvic ring injury, to hop from one department to the other and potentially go to the wrong way, missing operating room or missing embolization, which is at the moment in most hospitals in a different floor and requires completely different logistics. So my recommendation is that improve the patient flow, critically injured patient flow, all the way from the pre-hospital care to definitive management, and remove these historic blocks of jumps. And if you do this for hemodynamically unstable pelvic fracture patients which are likely to die, you will improve overall your patient care. And while the classic REBOA, blowing up blindly a balloon in the abdominal aorta, doesn't improve the outcomes of these patients, maybe in the future some selective balloon-based catheter enhanced techniques to selective vessels can help. And we've seen situations when we've seen a non-salvageable limb with a massive pelvic bleeding, blowing up the balloon in the common iliac, and then able to perform safely amputation and further hemorrhage control. So this could have a role, but they need to be a little bit more selective. And this has happened with angioembolization as well, that more selective techniques are actually helpful and associated with better outcomes. So the take-home message, and very simple 4 points, how should be the optimal practice in 2024 in this area. You need to make sure that in your trauma system, the expeditious direct transport to the trauma center in a binder in these patients is sorted. This is not trauma surgery. This is not hands-on things. This organization helps to save many patients, including these ones. And this is a system role what we assess on helicopter view, on trauma care verification, which can save many more lives than we can do as hands-on surgeons. The second is to bring hemostatic resuscitation as early as possible. And the data shows that in urban guns and knives clubs, if you have a patient transported by police or bystanders within 15 minutes in the hospital, this doesn't make a difference. But if beyond that time and in severe blunt trauma and pelvic ring associated bleeding, hemostatic resuscitation, having a couple of units of extended life plasma in a helicopter or in the ambulance can help these patients to stem the bleeding and actually later on eliminates the need for crazy cycles of massive transfusion protocol. The rapid selective angioembolization is a proven method for optimal care for these patients. And I showed you the examples and I explained in detail how can this achieved even in level 3 regional centers in Australasia. And in terms of us for trauma surgeons, the acute early definitive surgical care is crucial. Putting these patients in an external fixator or traction and wait for 4 or 5 days for developing complication or just to adjust to surgeons' convenience is just unacceptable. If this patient goes to a level 1 trauma center, you need to have a capability to manage this by specialist surgeons 24/7. And most of the time, you don't need to do it right on the spot, but within 24 hours, if it's related to bleeding, and if the patient goes to the operating room in that same go, this is the best thing to do. As a surgeon who operating on this regularly, I can tell you that reduction acutely is easy. You don't have the abdomen full of blood gases, which are obscuring your view. And if the patient can sit up on the ICU, ventilated properly, extubated on a timely fashion, and mobilized at least in bed, it just makes things very, very different. So this is my summary, and I hope I'm well within time and didn't complicate too much on the message. And I think the main difference compared to 2020, that what I'm stating today is less controversial. I was talking about this in a controversial fashion for decades and things like that. Luckily today I can say the same message with facts from all over the world. And I hope this will serve the benefit of these patients and better care around the world for this problem, which for a long time remained on the M&M meetings and mortality reviews as potentially preventable death due to hemorrhage. And I'm happy to answer questions via chat or the discussion. And thanks very much again, the opportunity to share my ideas about this topic.
Thank you very much, Jules. Very comprehensive talk, and yeah, well within time. We are very fortunate to have access to this wealth and breadth of experience in dealing with these injuries. And to that point, we do have expert panelists as well as a speaker. We have Professor Woolschlager from Queensland, Professor Weber from right here in Perth, and Professor Jeremy Sue in New South Wales joining us as panelists. So if If you have any questions, please type them on the chat. And I'm sure the panelists and our speaker are happy to answer them.
Can I go first, Martin, to get the
Yes,
ball rolling?
please. Yes, please.
And just encouraging everyone to put their questions up on the chat as well. And Joel, maybe if you unshare your screen so we can see all of the panel members' faces would be really good too. Hello, everyone. Excellent, thank you. So Joel, I think too, one of the things is that despite the encouragement we give people, the tyranny of distance is still, it's a hurdle I think that we're slowly getting over, but still needs a bit of work. So one of the questions I have for you is, as the receiving trauma surgeon in a major trauma service, is when you get that call from a regional service, when do you want to know about the patient when they hit that regional trauma service? Is it sort of assuming they're 2 or more hours away from you? Is it once they've been through the CT scanner? Are you happy that they've got signs of shock, they've initiated resuscitation, they've got a plain film that shows they clearly have a severe pelvic injury? Would you like to hear about them then, or would you like to have the CT scan first?
Well, yeah, we tend to hear about this in the pre-hospital phase, which is helps us to the decision making whether they logistically suitable to come straight to us or go to a regional hospital, and we have tend to have this three-way communication when it's suitable. If they land in a regional center, I would like to know about that as soon as they identify that the patient is in shock, and we have a 24/7 consultant trauma surgeon available to guide this management. And what I presented can sound a little bit black and white, but there is always logistical and individual differences which are happy to address, because there can be some other injuries. Some patients can have catastrophic abdominal injuries in the same time, and then we sometimes elect to get that controlled in this regional hospital and get to us from there. So as soon as they identify the patients in traumatic shock and is unlikely to manage them definitively, and as you said, it's enough to have an X-ray, and we are happy to discuss it. Actually, we want to know about it.
Thank you. We don't have any questions yet on the chat room, but can I invite any of the panelists? We have a panelist from Queensland, from New South Wales, and from here in WA. Professor Balogh mentioned something about earlier fixation means better outcomes, and I tend to agree. Here in WA, we can get pelvises fixed within 24 hours, but that is not usually the norm. We usually take a bit longer. What's it like in your states? Maybe we'll start with Martin.
Thank you, Martin.
Yeah.
Firstly, I would like to thank Zsolt for this compassionate presentation, and you have been working in this topic for years and years, and I congratulate you on all the studies as well and how far you have come, showing that the system can actually improve, and it did improve a lot. In terms of your question, Martin, in the centers, we are quite fortunate that we have now really the orthopedic departments have started to recruit specific pelvic surgeons. So in Brisbane and Gold Coast, we're fortunate to have enough to cover not 24/7, but definitely 5 days a week, and sometimes even on the weekends we get them fixed. So I totally support you, Zsolt, that those pelvises are fixed early. We don't fix off normally in the first 6 to 12 hours, but we've done it as well. And it's anecdotally for me rather, But if you put a couple of screws in the back percutaneously because you can, it actually helps bleeding a lot as well. So they improve very quickly as well. So I'm very supportive for early fixation. Also from my upbringing back home in Switzerland, we fixed other areas early, and there's big benefit for that.
We hear from New South Wales, Professor Sue, Jeremy.
Yeah, I mean, I think the only thing that I think that I would add, like, as into the talk, is kind of like what Jolt had um described through the talk, in that things have changed. We used to see bad pelvic traumas, and we just don't really, I mean, they don't seem that bad anymore, and certainly for us. I think it's a combination of all those factors that were described, as in the rapid pre-hospital uh, transport and care, and in particular the hemostatic resuscitation. And I think that certainly we don't, that group of that, I guess what would have been termed the sanguinating pelvic fracture patients, we just over the last few years have not really had the same sort of presentation and early course. I still think that open pelvic fractures are a big deal, and I think that that's a super important aspect that everybody should be aware of, and ensure that they Jolt said that these are managed in a different way because the pelvis is open, and I'm not talking about open book. So it means that all those things that are normally contained and would stop, like the venous bleeding, the bone bleeding, is not contained. And so it's actually a different approach to those injuries. And that's certainly just what we've observed. And I don't know, Joel, if you got any comments on that, like whether that's similar or the others?
Yeah, I think it's exactly the same, and that's why I dedicated maybe 5-7 minutes of my talk to the open pelvic ring injuries. Those are the situations where pre-hospital or emergency department packing of the wound and binding on the top of it essential, and early contamination and hemorrhage control. And the rest of the principles beyond that are the same, but actually just much more challenging. And the reason why we do early internal fixation on these patients, because they're not going to be a better time window. These patients going to be hyperinflammatory, potentially contaminated from urine and feces, and the best thing to generate a pelvic ring which can withstand every second day a lithotomy position, perineal wound washouts and debridements, and managing the complications.
If I may, there's a question online. Any nuances dealing with pediatric pelvic fracture in terms of epidemiology, injuries, pattern, and management? Are children small adults or not small adults?
Thank you very much, Michael. I think everybody is a human, and who are we treat as physicians, and the children are just small humans, and they have a specific injury patterns and specific physiology which we need to know exactly, as we know the octogenarians, elite athletes, or teenagers, or diabetic middle-aged people. So in these children, the pelvic ring injuries much more infrequent because the normal car crashes, falls infrequently cause pelvic injuries, but the infrequent pelvic injuries are much more catastrophic and tend to be more open. The typical injury mechanism in a child, especially in young children, toddlers, are run over by a car, at the street or is even in a family car backing out from the garage. And those patients very frequently have pelvic ring injuries, open fractures, and they're frequently associated with abdominal injuries just through the mechanism. Sometimes the abdomen bursts in the bottom to the perineum and up through the diaphragm as well. So multidisciplinary management is crucial, but beyond that, early definitive stabilization is very important, and you balance it for the optimal healing potential of a child. But basic principles are, I don't think they are different. The epidemiology is definitively different. And the problem is that many pediatric centers, standalone pediatric centers, don't necessarily have enough experience with surgical skills and everything else around. So I think in this matter, the close proximity and the combined adult pediatric trauma centers can perform very well.
Thank you, Joel. There's another online question. Is there any indication or need to wait or delay surgery in the current resuscitation environment if there is no coagulation abnormalities?
Well, I think there is no, you can delay surgery if a patient is not bleeding because you are not doing it for hemorrhage control, but the inflammatory response is not going to be better, and no patients benefit from broken pelvis lying in the bed for a certain amount of extra time. Analgesia, opioids, being on a ventilator, unable to mobilize are all major stress factors. This is how Jesus Christ died on the cross. And that's not tolerated very well by human beings. So to me, while you can delay if somebody is not bleeding, there's not much point in it. Some people delay it because the patient is bleeding, because they don't want to intervene, because they're unstable, which is again doesn't make sense because there is no other hemorrhage where we don't intervene and wait until the patient stabilizes. So to me, individual cases when there is higher priority or the pelvic ring injury is not catastrophic can be rational to wait, but in principle, just wait for a imaginary time frame, I don't think is really warranted.
Thank you, Joel.
May I ask another question, Martin? Is that
yes,
all right?
please, go ahead. Yeah.
So, and this is probably open to any of the panel members, but probably Martin Bullschlager and Joel together. Just as we see more of these patients survive their trauma, their multi-trauma, but in particular their severe pelvic trauma, we do see a lot more survivors with significant pelvic floor dysfunction, sexual dysfunction. Are there any sort of recent updates in the area, particularly say of pelvic floor dysfunction and of incontinence? We do stomas very early for these patients, particularly with the open wounds. But are we moving towards any form of treatment or anything that you can update the audience on with regards to, particularly with fecal continence moving forward?
Martin, go ahead.
Thank you, Kate. That's a really difficult question. I don't think there is any too much of an update. The early management, as you described, is early colostomy is definitely warranted in perineal compound injuries with inclusion of sphincter, anal sphincter, plus or minus rectum. That's at least the latest. There's no hard evidence and soft evidence for that. In terms of management afterwards, once the nerves and I think to reduce the pelvis as early as possible, as we do in spinal fractures, and again, I don't think there's any evidence, but John might correct me, that you have a better neurological outcome. It's hard to tell, but it might be, I guess it makes sense, to reduce the sacrum early and potentially have some freed up nerves and fragments as well out of the way to improve neurological outcomes. But that's all. I don't think we can ever prove that. Now, recovery, it takes a long time. Allied health is important with pelvic floor, physio, and all of that. But ultimately, if the sphincter if there is a fecal incontinence, it's hard to get to a functional outcome again. I mean, there are pumps and other options for functional reconstruction, but in this particular cohort, there's no evidence for it. There might be single cases that have a better outcome, but unfortunately, at least in my experience, most of those patients, they stay with a colostomy, and they're in acceptance of it. Some not so much, but most of them they're happy actually to be alive. I think that's the big picture as well, because 20 years ago, as we heard, they would be dead, and now they are alive, and some of them have quite a good life, quality of life. I think one other big problem is pain. So that's what we have in our follow-up studies that we now do. 1 year follow-up, pelvic fractures have a really high pain. They have a lot of pain still, even after 12 months, up to 50% of those patients. And we're not on top of that, how to actually manage it other than pain management. Scholt, anything to add from your end?
I think you perfectly summarized the early management, early operative management have the theoretical advantage, like any compressed nerve root. If the only chance if they have is they decompress earlier. The late reconstructions of neurological problems from pelvic floor, we need to watch the advances in colorectal and urology surgery, where they have some methods for late reconstruction. The sexual dysfunction is, I don't think we have new data apart from frequent in terms of getting better or not. I think the only major breakthrough in this topic, what you alluded to, that in pelvic perineal open wounds, we only divert those patients who have associated anorectal injury, because no matter how bad is the perineal wound, with advanced wound management techniques, especially the patient is not going to open their bowels in the first 48, 72 hours. That time frame is usually enough to temporize that wound and avoid mandatory colostomy. But otherwise, that's pretty much where we are. We need more survivors regularly to be able to show long-term benefits.
Dieter has a question. You can actually ask your question live here, Dieter. Yeah,
yeah, sure. Going back a bit, actually, and thanks for that discussion, because I think we do need some more functional outcomes in the long-term data with these patients. But what are we going to advise from our ivory towers in our level 1 trauma centers to our rural colleagues that are realistically 6 to 12 hours away from having that patient in a place where we can angioembolize them? How do we best support that rural sector? Any other comments on that?
Well, my comments, Dieter, were related to the roughly 4-6 hour time frame. I think you are in a special situation, and some of our Queensland colleagues and maybe Northern Territory and South Australia who received from the far north patients. And for them, I think early communication on individual basis and these regional receiving centers need to have somehow angiography facility, because there are two types of patients who don't have arterial bleeding. They're gonna make it to your center. Maybe they're gonna be less optimal and more inflamed state, but they will survive. The other ones who have arterial bleeding, in that time frame, you can't afford the transport. And that's where it comes down that if these patients have a regular, some sort of vascular service, then probably worthwhile to develop those skills.
Do you see a role for empiric angioembolization in that setting then, as a very basic sort of skill, bilateral internal iliac artery gel format?
Not really. I wouldn't do it without. If by the time a center have this facility, they will have the facility to do a CT scan, and which is much logistically usually much easier. So I would say that sometimes you can go empirically where it's more likely, but doing this regularly on diagnostic or therapeutic angios, we see that the bleeders can pop up in the most unusual spots. There are a few things where you can roughly think where the bleeder is, but in a grossly displaced pelvis, which I just showed in the beginning, theoretically anything can bleed.
So sorry, I meant post CT scan, obviously.
Yeah, post CT scan, if you don't have the advanced skills, probably more proximal embolization is a reasonable thing. I think it's very unlikely to need a bilateral, but taking out the proximal internal iliac with a giant coil, it's potentially making sense.
Thank you very much. If I may have take this moment to ask Zsolt as well. When I first started as a consultant here in Royal Perth, we were doing some REBOAs with some degree of success, as Dieter can attest. Is it really your position that they really do not have added benefit?
Well, to me, blowing up a balloon and excluding half of the human body, and after that reperfusing is a perfect model how you generate multiple organ failure in laboratory animals. This is the absolute blind and fixed complete occlusion. Now, if your place is able to do this slightly more selectively and doing a partial occlusion, or do it in a quick, small, quick arterial femoral line, which you can put a low caliber balloon, and when you hit the patient in an environment where you can selectively do things, I think it has a role. And I just cannot exclude it as an option. But regularly seeing, oh, bad pelvic fracture or potential pelvic fracture, and let's blow up a balloon, I think that's generate more complications and potentially preventable deaths than the actual margin who really benefit from that. I'm sure there are anecdotal experience that in one or two patients can make a difference, but then you need to deflate sometimes that balloon, and they need to provide hemorrhage control either way. And I much prefer to be straight away in the place where it can be done. And this will be, I think, the hybrid CT rooms where everything is available, and you do it straight away, and you do it under control and just as long as you really need. And you can inflate, deflate, and so on. So I won't exclude completely the opportunity, which I don't think just our methods are there.
Thank you very much.
Thanks for that. It was really nice to hear the sort of challenging aspects of also these multiple primary surveys, Martin. I think those comments overlap there. Do you see us, Zsolt, moving towards more shock room, hybrid room receptions as we redesign EDs into the future?
I think one of my, when I look at our mortality reviews in our trauma center and looking at potentially or marginally even preventable deaths, all the time the issue is related to somehow logistics and the decision making and timing, and you know, giving 3-factor or 4-factor prothrombin concentrate in these patients, one or the other, I don't think would make a difference. It's all about logistics, and I'm really into changing the workflow for these patients and the hospital journey for a better one. And this is primarily driven by better and faster pre-hospital care and more aggressive one. And the second one is better imaging and potential bringing services together which were historically in completely different places. But this can be only done if these hybrid rooms are dedicated to trauma patients. And the only way you can achieve that if you do their regular imaging and bringing anybody up straight away who needs some sort of operation, even if that's not life-saving, but urgent. So in that case, you can keep that operating room, hybrid room for the trauma service and supporting service instead of having that for elective vascular and you are never able to break in. Or when you can break in afterwards, the room is not stopped.
Yeah.
All right. Thank you very much. I don't show any more questions online. Are there any more comments or questions from our panelists?
Oh, I just wanted to check what people's practice is, again, with the pelvic fractures, those at the open pelvic fractures, in terms of that balance between pelvic ring stability and contamination. Like what is all your practice with regards to, you know, like if there is a very unstable bony pelvis, but there's significant soft tissue defect that, you know, exposes bone. You know, obviously they've survived the hemorrhagic phase. They're not bleeding to death, but now they're in that significant contamination, you know, where they may have devitalized tissue, repeated, you know, return to theater for washout, debridement, but the pelvis is still unstable. What's the timing or the recommendation for timing of fixation, and what sort of fixation? And then, you know, do you allow the plastic surgeons to do a flap coverage? Do you want them to, you know, put a flap in the early stage? Really around that aspect.
Can I go first as the non-orthopod?
Yeah.
So we're seeing, so I've worked in 2 institutions, one where there was a lot of X-fixes, virtually everybody got an X-fix and then definitive, and now I work in an institution where we do very few external fixators, but this may be one of those instances, at least initially, or in-fixes. I've seen a few in-fixes now. So it is a curved bar. It is internal and it's usually across the front of the pelvis, and there may just be a screw in the back. The orthopedic guys still try to get at least a percutaneous screw in posteriorly, which I think can be done in a lot of these cases. That will look after the back of the pelvis. And then it's controlling that contamination. Almost always those patients will end up with a colostomy Initially, they'll have a repair of their anal sphincter if that's been involved as well. And then it's just a matter of when the orthopedic guys are happy enough that they've got the risk of putting internal metalware in as low as possible, which is really a zero risk. But that's certainly the practice I'm seeing here. It's very much a multidisciplinary discussion. There's a lot of discussions between the general trauma surgeons and the orthopedic surgeons as well. A lot of discussion goes on between the two. But that's one approach that I'm seeing more and more of.
Well, in my principles in here and other open fractures, that you can't achieve soft tissue healing and stability without stabilizing the skeleton. And most of the time, external fixation doesn't provide this good enough, just because the frame is too far from the level of the injury where the problem is. So most of my open pelvic fractures get acute definitive internal fixation before they can have these problems what you just mentioned, Jeremy. And if they have a open injury, we fix the pelvis, and in the same sitting they get the colostomy if they have anorectal injury, and then we deal with the open wound. And I accept that this hardware get infected, but actually the pelvic ring and the soft tissue coverage have a good ability to manage this, and you frequently achieve pelvic ring stability and union, and then you remove the infected hardware in the planned fashion. The other option is to having a completely displaced unstable ring, and every time everything is moving and you never have a union, and your orthopedic colleagues never find a happy window because things, as you know, these open fractures with perineal wound, they spend in a hospital months and they have dozens of operations, and the things just get uglier and uglier before it gets better. And to me, you consent the patient, you accept the risk for hardware-associated infection. It's infected anyway from the start, so you just need to take the lower risk for at least have a stable ring to handle the infection.
Do you use antibiotic beads?
Yeah, we tend to use that, and silver foam, wound vac, and instill wax with local antibiotics and anything which potentially feasible, but it's largely evidence-free zone and applied from other areas to here.
Martin W. Yeah.
Yes, perhaps I totally support what George said in terms of you need the stability, and I've done neck fixes as well in the past, but I do them rarely. If it's really the badly compound and difficult fracture patterns, and only for 2 or 3 days, and then start with just screw fixations on the back, definitely percutaneous, but also on the front. We can do now anterior column, posterior column, and all sorts of percutaneous screws, at least to temporize it as well, to get over the first period of a couple of weeks, and then might fix more, but often it's not even necessary as well. And in terms of implants getting infected, I have the same experience as Sean. They do get infected, but even with VAC, it closes up, metal on view sometimes, and then it closes over with VAC dressing and some not even plastic surgeons, just us moving soft tissues around, and they heal. And if they don't heal after 6 weeks or so, they take the implants out. If you have a fistula or a sinus, then the pelvis is already quite stable. So yeah, I feel it's the debridement is important. So once we are past the stage of bleeding control, doing good debridement to get on top of infection or not infection, so preventing infection as much as possible. And then using the VAC dressings, we do that regularly, regular washouts, but then also using the remaining soft tissues. And if you have hemi or exarticulations or hemipelvectomies, very challenging as well, but using the remaining soft tissue to cover it as soon as possible.
You do anything different in WA, Dieter and Martin J?
Not really, quite the same. We see a lot more X fixes if it's really bad pelvic fracture with extensive soft tissue injury. One thing we try to do is if we're suspecting that pelvic sepsis is going to be an issue, we try to involve our colorectal colleagues as early as possible as well.
Right.
Yeah. All right. I've got no more questions on the chat room. Are there any more questions or comments from our panelists or our speaker?
I think you guys are covered it very nicely.
Yeah. Well, thank you very much, Joel, for a very comprehensive talk. And thank you to the panelists and to the members for your continued support of this process. As Kate said, it was this topic that was the first inaugural speech talk as well in 2020, and I think we've brought things full circle now, and I'm excited for the future. Thank you.
And just reminding everyone, our next Trauma Grand Round will be on Tuesday, the 1st of October. So we'll get some comms out to everybody for then, but thank you very much for your time.
All right. Thank you, everyone.
Good night.
Good night.
Thank you.
Thank you.
Martin Schultz and everyone.
Thank you.